We're going to talk about medications for hypertension, angina, heart failure, and dysrhythmias. Now, this might seem like a lot of disease processes to talk about all at once, but what you'll see is that many of the medications cross over and treat all or a couple of these things. So it's hard to separate them out because we just end up talking about the same medications over and over again. Now, I'm not going to spend a lot of time talking about each disease process, but just want to do a quick overview. So when we're talking about hypertension, you know the parameters, but what you need to understand is the disease process itself, what's going on pathophysiologically that is causing the hypertension. So we need to remember the three things that affect blood pressure, and this is cardiac output, peripheral vascular resistance, and blood volume. So a change in any of these things can cause blood pressure to go down, or it can cause blood pressure to go up. You also need to remind yourself what controls cardiac output. And cardiac output is controlled by heart rate and by volume. So if we change the heart rate, but leave the volume the same, cardiac output is going to change. And if we change cardiac output, in turn we're going to change blood pressure. So all of these medications have the potential to change one of those factors, either heart rate, cardiac output, peripheral vascular resistance, or blood volume. And again, a change in any one of those things is going to change blood pressure. There are also nervous and hormonal factors that we have to consider with blood pressure control. And one of the biggest things is the vasomotor center, which controls the constriction or dilation of the peripheral vessels. We also have baroreceptors, which sense whether the blood pressure is elevated or low, and if the blood pressure drops too fast, then we get what's called reflex tachycardia. And if you take that back to when we talked about what controls blood pressure, if the blood pressure drops suddenly, the heart rate goes up. Well, what is that going to do? It should increase cardiac output if the volume is the same, and thereby increase blood pressure. Emotions play a role, and then we have various hormones. We have the renin-angiotensin pathway, and that's one of the biggest hormones. Involves renin, angiotensin, and aldosterone, and that plays an important role in hypertension and heart failure, and we'll talk a little bit more about that when we talk about prils and ARBs. Heart failure is, we call it a disease process, but it's really a cluster of signs and symptoms. And you probably remember that heart failure is really about when the heart becomes an inadequate pump. So when the heart becomes an inadequate pump, then cardiac output is going to fall and tissue perfusion decreases. Depending on whether it's the right side or the left side of the heart that becomes an inadequate pump, we see the different symptoms. Regardless of which side it is, fluid imbalance becomes an issue, as well as tissue perfusion. And that poor tissue perfusion plays a role in some of the compensatory mechanisms that we see. And it's those compensatory mechanisms that stimulate the sympathetic nervous system, stimulate the renin, angiotensin, aldosterone system, and stimulate ADH. all in an attempt to improve cardiac output and improve tissue perfusion. And then angina. Angina occurs when the myocardium, the muscle of the heart, doesn't get enough oxygen supply. So we get decreased blood flow to the myocardium when we have coronary artery disease, usually because of atherosclerosis, which blocks or totally stops that blood flow. So when it totally stops it, then obviously we have a myocardial infarction. But when it's just partially blocked, we have angina. So a portion of the myocardium becomes hypoxic, and anytime a muscle doesn't get adequate oxygen, we're going to have discomfort. Two types of angina, stable and unstable. The basic premise is the same. For whatever reason, the heart muscle isn't getting adequate oxygen supply. And then dysrhythmias are typically caused by an alteration in the electrical conductivity of the heart. This can be caused by electrolyte imbalances. Potassium, we all know, if it's too high or too low, is going to cause dysrhythmia, and that's the main thing we're going to look for with altered potassium. Sometimes instead of the SA node being the primary initiator of the impulse, the AV node will take over, or some other portion. So we're going to talk about medications that will help that. So all of this is just kind of a quick review, not intended to be testable information, but you need to understand that pathology in order to understand how some of these medications will work. So, as a general rule, when we're talking about hypertension, we use 2 or more drugs from different classes to control the blood pressure. That way we can use lower doses of each drug and get fewer side effects. And with fewer side effects, we get better patient compliance. Now, a lot of times patients don't want to take medications, and so we can tell them to do these things that are listed. Some people would rather take a pill than have to change the way that they live their life. And so we have medications available. So one of the medications that we're going to use is an ACE inhibitor. So who is ACE and why should we inhibit him? Inhibiting ACE increases waste. Now, ACE is angiotensin converting enzyme. So if you think about that name, it means that there's an enzyme that changes angiotensin. Well, what is angiotensin changing into? So this goes back to the renin-angiotensin-aldosterone system or pathway. So this is how I like to tell this story about renin-angiotensin-aldosterone. So ACE is Angie's best friend, angiotensin. So when we have decreased perfusion to the kidneys, remember I told you kidneys not very smart, easily insulted. So anytime they have a slight decrease in blood flow, they start sending out hate mail, sending out emails, hate everybody. So the first message they send out is renin. And renin then tells the liver sends a signal, the message on to the liver to secrete angiotensin. Well, Angie 1 leaves. She is dressed like she's going to go to school. And immediately calls her friend Aldosterone. Now, Al is a party guy. He's the one who brings the party goods. His role is to bring the sodium, and in turn, we all know that sodium is followed by water. So he brings the salty snacks and the drinks. So Angie 1, the schoolgirl, calls Al to bring the party goods. Angie 1 then goes to change. She changes into Angie 2. Angie 2 is a party girl. So Al and Angie then because of ACE, Angie 1 changes to Angie 2 because of ACE, and they go party. When they're partying, they're taking in all these salty chips and drinking up all this liquid, and now we have increased blood volume, which is going to increase our blood pressure. So, what happens then when Renin calls Angie 1, Angie 1 can't call Al because ACE has, if we inhibit ACE, we get ACE out of the picture, then the phone line, no cell reception from Angie 1 to Al and Angie 2. So, in a nutshell, it's all about the party. So, when we're talking about ACE inhibitors, we want to pick a prill, any prill. What does that tell you? It tells you that all ACE inhibitors end in prill. So, a couple of examples are enalapril, lisinopril. They all have various trade names, but if they end in prill, then they block the angiotensin converting enzyme, and they keep Angie 1 from changing into her party clothes and calling Al and becoming Angie 2. So they're not bringing sodium and they're not bringing water. This, in effect, results in vasodilation and an excretion of sodium. And if we excrete sodium, we're going to excrete water and decrease our blood volume. And if you go back to think about what were the causes of hypertension, if we have increased peripheral vascular resistance in the form of vasoconstriction and increased blood volume, those things are going to increase our blood pressure. So by inhibiting ACE, we keep Angie and Al from having a party. They can't bring sodium and they can't bring water. All of that stuff gets dumped out through the kidneys. The kidneys are happy. They resume doing their job. So, we have improved cardiac output, we have decreased peripheral vascular resistance, and we have decreased volume. The prills or ACE inhibitors are usually the first choice for high blood pressure and for heart failure. They're frequently used with a diuretic, and they're always used with a diuretic for African Americans because they're not effective for African Americans without a diuretic. So ACE inhibitors function as antihypertensives. They are used to treat heart failure. They do have some anti-inflammatory properties, antithrombotic properties. They are mildly hypoglycemic, sorry about that, and they decrease remodeling of tissue, so they prevent tissue from being broken down and rebuilt. which is useful in myocardial infarctions. Side effects, one of the major side effects is a persistent cough. This can be bad enough that it causes the patient to want to switch, though in and of itself it isn't a problem. Angioedema, on the other hand, is a problem. This is going to be exhibited by hoarseness of the voice, progressing to difficulty breathing. So if a patient on an ACE inhibitor develops a change in their voice, this can be a symptom of angioedema, and the healthcare provider needs to be notified immediately. Hyperkalemia is also a side effect, and another reason why diuretics are frequently used with prills is because most of your diuretics decrease potassium. And so we use a prill with, say, a thiazide, and we get a balance in our potassium. Since thiazide diuretics are potassium wasting. The prills do interact with NSAIDs. Remember we talked about how NSAIDs decrease blood flow to the kidneys, which in turn is going to decrease the glomerular filtration rate, meaning we're not going to excrete sodium, and therefore we're not going to excrete fluid. So they kind of balance each other out if we take a lot of NSAIDs when we're taking a prill. Antacids decrease the effectiveness of ACE inhibitors, beta blockers, and other antihypertensives are going to increase the effect, causing lower blood pressure, which again may be the desired effect. Maybe we want the blood pressure lower, and we can use lower doses of each. Digoxin levels can be altered. It's not consistent. It's going to depend on the person. It can increase the dig level or decrease the dig level. And they are teratogenic. Sartans. Sartans are the princes of ARBs. ARBs are angiotensin receptor blockers. So, in this case, Angie gets the call from Renan. She goes to change from her schoolgirl clothes to her party girl clothes, calls Al, they get all their party stuff together, and they get to the club. They get to the club, and there's this big burly ARB standing there. He's a big guy. Big, puffy biceps, t-shirt straining across his chest, arms crossed. Thou shalt not pass, he says. Sends Angie and Al home. Doesn't let him in the club. So sartans are just as effective at lowering blood pressure in the sense that we're not going to see the vasoconstriction that would be caused when Angie and Al get together. We're not going to see the fluid buildup, the sodium retention that we see when Angie and Al get together. It's just a slight difference in their mechanism of action. So when we use an ARB, we get arterial dilation and increased sodium excretion, which decreases fluid or increases excretion of fluid. And so both those things together are going to lower blood pressure. Side effects, obviously hypotension is going to be a side effect for any of these medications. And again, hyperkalemia. When we lose sodium, the body has a tendency to retain potassium. Sartans can be used with the prills. It may take 3 to 6 weeks to see a therapeutic effect. GI symptoms are common but usually resolve over time. Headache can occur. Sometimes the headache occurs because of the vasodilation, and this will resolve over time simply because as the body adjusts. But initially, the head only has so much room, and we dilate the vessels in there, it's going to cause some discomfort. But if we, as the body starts to get rid of the fluid, and don't have too much fluid, and the body adjusts to the vasodilation, that headache will go away. Persistent headache, though, needs to be evaluated to make sure that the medication is actually working and that the headache isn't a result of continued high blood pressure. Diuretics and beta blockers are going to obviously increase the effect of ARBs, and alcohol will increase the effect of ARBs as well. Now, alpha-adrenergic blockers are the Zosins. Doxazosin, terazosin, brazosin. So, if it's a Zosin, it's an alpha blocker or adrenergic blocker. They obviously, just like their name implies, block the alpha receptors in vascular smooth muscle. Now, what do these receptors do when stimulated? They cause vasoconstriction. So if we block them, we're going to have vasodilation. Vasodilation then is going to decrease peripheral vascular resistance and decrease blood pressure. The advantage of the Zosins is that they decrease peripheral vascular resistance without decreasing cardiac output, which is very important, and they don't cause that reflex tachycardia. Doxazosin has a long half-life, so once-a-day dosing is possible. The nice thing about alpha-adrenergics or adrenergic blockers, is that they are very well tolerated by African Americans and are frequently the first choice for blood pressure control for that population. Orthostatic hypotension is common, especially after the first dose. So we need to teach patients to rise slowly, lie down if they feel dizzy. They will eventually develop a tolerance to that, and it won't be bothersome anymore. Now, we always want to check blood pressure before giving an antihypertensive, but especially with the alpha blockers. If the systolic blood pressure is below 100, or the heart rate is below 50, we need to hold the medication, or whatever the physician has ordered. We also want to check to make sure that they aren't pregnant. So obviously side effects are lowering the blood pressure too much. Bradycardia can also cause dry mouth and headache. These two effects can be develop tolerance over time. Diuretics, alcohol, other antihypertensives are going to cause more lowering of the blood pressure. LOL, lol, no laughing matter. If it ends in lol, alol, illol, olol, then it's a beta blocker. Beta blockers obviously block beta. You remember about beta receptors found in the heart and in the lungs. Some beta blockers are selective and some are non-selective. What is the neurotransmitter that's being blocked? Correct, epinephrine and norepinephrine. So they're blocking that neurotransmitter, and if it's non-selective, then it's going to block multiple. So in this case, carvedilol and propranolol are non-selective, They block beta 1 and beta 2, and alpha 1 for carvedilol, and just beta 1 and beta 2 for propranolol. The beta blockers have multiple uses. They're useful for dysrhythmias because of their beta 1 blocking. Useful for hypertension, especially when the patient also has coronary artery disease. Because these drugs block beta 2, they should not be used in patients with asthma, with type 1 diabetes, peripheral vascular disease, and in some instances with heart failure as well. So when we're blocking these beta receptors, we're going to slow the heart rate, which reduces the blood pressure because it decreases cardiac output. It also decreases the workload, and that's how it can help with coronary artery disease. It's going to help with angina. It also inhibits renin, the beta blockers do, which is going to allow for vasodilation, which in turn decreases cardiac output because it decreases preload and afterload. And because it inhibits renin, it helps to excrete more sodium. If renin doesn't get sent out with that initial message, Angie 1 doesn't change to Angie 2, Angie 2 doesn't call Al, and they don't get to have their party. We always want to assess respiratory history of respiratory disease, diabetes, heart failure, peripheral vascular disease prior to implementation of beta blocker use. Side effects, obviously, bradycardia, because it lowers the heart rate, hypotension, because it lowers the blood pressure. So these are things that we definitely want to assess prior to giving a dose of this medication. It can worsen heart failure because of the bradycardia and the reduced contractility. Okay, sorry, I got interrupted. So where was I? Interactions. Phenothiazines will increase hypertension. MAOIs will increase the risk of hypotension and bradycardia. Albuterol, which is beta adrenergic and used for asthma, will counteract the effect of the beta blocker. So we may not see relief of the asthma attack, and we may see an increase in blood pressure. DIG used with beta blockers may increase the levels of digoxin, and because of the risk of hypoglycemia, we may need to alter insulin or oral hypoglycemic agents. Okay, what's a LOL? You remember that it's a beta blocker. We just talked about it. But these are a couple of different kinds. Atenolol and metoprolol, again, they end with lol. These two are these are selective beta blockers. They target only beta 1. And remember, beta 1 is only in the heart, one heart. And they primarily are going to slow heart rate and reduce contractility. So their use is for angina and MI, myocardial infarction. What happens by slowing the heart rate and reducing contractility, meaning the heart isn't contracting as forcefully, then we reduce the oxygen demand by the muscle of the heart. This is going to relieve the discomfort of the angina and allow the muscle to rest somewhat, even though we don't want the heart muscle to rest completely or for a long period of time, because then it's not doing anything, to allow the heart muscle to begin to heal after an MI. Side effects of atenolol and metoprolol, because they are essentially reducing cardiac output as well, would be fatigue, weakness, and hypotension. Most of your beta blockers, especially atenolol and metoprolol, though, are going to interact with calcium channel blockers, which we haven't talked about yet, but we're going to get excessive cardiac suppression, meaning slowing the heart rate or reducing the contractility too much. It's also going to interact with digoxin by slowing the conduction too much and leading to heart block, which would essentially stop the heart from contracting. Nicotine and caffeine are going to interact with all of these blood pressure medications simply because they are vasoconstrictors, and is going to be counterproductive to what we're trying to do. Direct-acting vasodilators have many different names, but you can tell just by the name vasodilator what they're going to do. Because they're direct-acting, they act directly on the muscle wall of the arteries to cause relaxation and thus vasodilation. So we have hydralazine, minoxidil. You may recognize minoxidil as the active ingredient in Rogaine, and nitroprusside. So these are examples of direct-acting vasodilators. Primarily, they're used in severe hypertension and hypertensive crisis, perhaps to bring the blood pressure down quickly in severe hypertension or in crisis, as opposed to chronic hypertension. Usually the patient is already on other antihypertensives when these medications are added. Minoxidil obviously is going to cause hair growth, and it may or may not be hair growth in appropriate places. So that would be a side effect, obviously. Implications: we're going to hold the dose if the heart rate is below 50 or as otherwise directed. And this is another medication that we're going to start low and go slow. We don't want to start with the highest dose simply because we don't want to bottom out that blood pressure. And certainly a side effect is going to be hypotension. Now this is where those baroreceptors that we talked about earlier are going to come into play. Because we're dilating those vessels, the body is going to get the signal that, hey, the volume has decreased, cardiac output has dropped, and so I need to do something about that. And when cardiac output falls, especially related to decrease in volume, the first thing the body wants to do is increase the heart rate, because it's all about maintaining cardiac output. And so this is where that reflex tachycardia is going to come into play. Trying to get that cardiac output increased again. Sometimes we can add a beta blocker, or if the patient's already on a beta blocker, with one of these vasodilators, and we won't get the reflex tachycardia. So reflex tachycardia, primary side effect, and because there's the potential to decrease tissue perfusion, remember those kidneys easily insulted, glomerular filtration rate is going to be reduced, and so sodium and water are going to be retained because renin, Angi, Al, all of those are going to come into play again in an attempt to retain fluid and get the volume increased. So we're usually going to use it with a beta blocker to control these side effects. Dizziness, numbness, nausea, and orthostatic hypotension, palpitations are also potential side effects. Reportable side effects will include fever, chills, joint pain, and a rash. It's going to interact with other antihypertensive MAOIs because we're going to see an increased hypotensive effect. NSAIDs are going to decrease the effectiveness of the vasodilators. Kind of makes you wonder why you would ever take an NSAID, especially if you have high blood pressure. So if they seem to work very well for some pain, huh? Now, calcium channel blockers, again, have different names. One thing that you can rely on with calcium channel blockers is that all dipines are calcium channel blockers, such as nifedipine. But not all calcium channel blockers are dipines, such as verapamil is a calcium channel blocker, but it doesn't end in dipine. Calcium channel blockers work by blocking calcium channels in the myocardium and vascular smooth muscle. Calcium is one of those ions, just like sodium and potassium, that when it moves across the cell membrane causes an action potential. In the case of the myocardial cells and the muscle cells of the arterial walls, when calcium moves across, it causes that cell to contract. So when all those muscle cells contract, then we get vasoconstriction, or we get contraction of the heart, so it pumps blood out. So we're going to use a calcium channel blocker to cause vasodilation, or allow at the very least, allow those vessels to relax, so we don't have as much peripheral vascular resistance, and to decrease the heart rate because those cells aren't going to contract as readily in the myocardium. So essentially, what calcium channel blockers are doing is slowing the speed of conduction across the cell membranes. And again, calcium channel blockers, very effective for African Americans, and are often the first choice for blood pressure control in that population. Because they decrease the workload of the heart, they are useful for angina. If we decrease the workload, then we decrease the oxygen demand. And so we're not going to have as much discomfort, because the blood supply that's being supplied will be adequate. And we reduce by dilating the vessels, we reduce the amount of work that the heart has to do in order to help with heart failure. It works to decrease blood pressure as well. Calcium channel blockers work as well as diuretics and beta blockers together. Side effects typically are related to vasodilation. And so again, headache is going to be one of those side effects, because we get vasodilation in that closed space. Dizziness because of the drop in the blood pressure, flushing because of the vasodilation. Constipation. Now, constipation is an interesting side effect, you might think, but again, it's not going to be heart specific or specific to the muscles of the arteries, and calcium is one of the ions that causes that the movement of calcium across the cell membranes of the intestinal tract causes peristalsis. So we're going to block that as well, cause decreased peristalsis of the intestines, and lead to constipation. Orthostatic hypotension can occur, and of course edema. And again, edema is one of those side effects that, if you think it through, you can figure out. If I dilate the vessels, and it's not just arteries, then return of fluid in the vascular system is going to be diminished. We're going to have more stagnation, more pooling of blood, and some of that fluid is going to leak out and cause edema. Interactions to be aware of: grapefruit juice increases absorption of calcium channel blockers, and this is going to alter the action. And so patients should avoid grapefruit juice unless told otherwise. Perhaps they're not getting adequate effects. But as a general rule, grapefruit juice should be avoided. Alcohol increases vasodilation, so orthostatic hypotension. I drink, I get drunk, I fall down. If you're taking a calcium channel blocker, it's absolutely going to happen. Nicotine, again, vasoconstriction, so it's going to counteract the effects that we're looking for. Now, another calcium channel blocker is diltiazem, and or cardiazem is its trade name. Again, it inhibits calcium movement, so it relaxes coronary arteries and peripheral blood vessels. So again, useful for angina, but it also is going to affect cardiac rhythm or electrical conduction, and so it's useful for dysrhythmias as well. Again, side effects are related to vasodilation, so you can figure out what those are going to be. Calcium channel blockers may not be useful for heart failure, or at least diltiazem, and it can increase digoxin levels. Anytime we use multiple antihypertensives together, we increase the risk of hypertension, increase the risk of dysrhythmias. So we're always going to monitor patients closely, especially when they're on multi-drug therapy. Verapamil, mentioned it earlier, again, inhibits flow of calcium into the myocardial cells, primarily used for dysrhythmias and angina, similar side effects, similar interactions. You'll see on some of these drugs, such as some of the calcium channel blockers, some of the potassium channel blockers, that they have class 3 on them, and like this calcium channel blocker has class 3. And it's labeled in classes when we're talking about its use as an antidysrhythmic. And at this point, that's really all you need to know about it, other than it's a calcium channel blocker. Potassium channel blockers are also class 3 medications. I'm kind of looking for, somehow I've lost that sheet. But amiodarone is probably the most common. You may have even given it in clinical. Its mechanism of action is very similar to calcium channel blockers, except that it's blocking the potassium ion. Again, you know that potassium is essential in heart rate and rhythm, and by having a change in potassium levels affects the rhythm of the heart. Potassium channel blockers prolong the refractory period, meaning that they prolong the duration of action of the contraction of the myocardial cells. So they keep the cells resting so that it doesn't fire as soon. And this is particularly useful in when we have tachycardia. So potassium channel blockers can stabilize dysrhythmias. They decrease heart rate, and by decreasing heart rate, you're going to decrease cardiac output, and that can be useful to decrease blood pressure. When amiodarone is first started, typically the patient needs to be hospitalized because it can worsen dysrhythmias. Patients can have pneumonia-like symptoms, severe bradycardia, and severe hypotension. So these side effects frequently can limit its usefulness, but we certainly are going to use a very small dose, and the patient needs to be observed closely initially. It can increase digoxin levels. It can enhance the effects of anticoagulants, enhance the bradycardic effect of beta blockers, and elevate phenytoin levels. Which, remember, phenytoin is Dilantin, which is an anticonvulsant. So primarily we use potassium channel blockers for dysrhythmias. The cardiac glycosides, digoxin is the main one that we use. Lanoxin is its trade name. Cardiac glycosides work by increasing the force of contraction of the heart by altering electrolytes and suppressing the AV node. Suppressing the AV node slows the electrical conduction, allowing the heart to fill completely, and then when it contracts with more force, it empties more completely as well. And so because of that, we call this a positive inotropic effect. It's useful in heart failure. Digoxin used to be the first line of defense for heart failure, but newer, better medications have come along. We still see patients all the time taking digoxin, but it's not always the first line of defense. It has a low margin of safety. It has a long half-life. Many other medications that we use to control blood pressure interact with digoxin. So we have to monitor it closely. Like I said, it has a very narrow margin of safety, so lab values have to be drawn frequently. If you've given it before, you know you have to take an apical pulse for a minute before giving it. It needs to be held if the heart rate is below 60. If the heart rate is over 100, then we may need to be holding the dose, certainly checking with the healthcare provider prior to going any farther. Make sure the dose is adequate. And it should be given after meals. It interacts with diuretics, which can cause hypokalemia, and hypokalemia is going to increase the risk of dig toxicity. So we want to make sure that the patient has adequate potassium levels. Side effects include GI symptoms, nausea, diarrhea. Dysrhythmias are a side effect, and headache. Nausea is something that we want to pay attention to. It can be a normal side effect, but it's often an early sign of digitoxicity. Phosphodiesterase inhibitors, such as milrinone, are also used for heart failure, especially if they're not responsive to ACE inhibitors or cardiac glycosides. They're typically for short-term use. They work by blocking, obviously they're inhibitors, so they block phosphodiesterase enzyme, which allows for more calcium to be available to the myocardial cells. By having more calcium available, it increases the force of contraction and allows for vasodilation. The biggest side effect is ventricular dysrhythmias, so we need to be monitoring that apical pulse again so that we can hear pauses or alterations in the rhythm. Doing the pulse deficit, is there a difference between the apical pulse and the peripheral pulse? Milrinone is only given IV and is limited to 2 to 3 days use. So this is going to be used when the patient comes in with exacerbation and they've already been on ACEs, they've already been using cardiac glycosides, and nothing is working, and they need something to relieve their symptoms. One thing that's not on here, so I backed up. It's going to be really kind of weird for a second, but one slide that's missing is a slide about nesretide, which is a natriuretic peptide. It acts on the kidneys to excrete sodium and water, which is going to lower blood pressure, allow vasodilation, which reduces preload. Now, preload and afterload, remember, you have to go back to look at heart failure. But if we reduce preload's the amount of blood coming into the heart, then the heart doesn't have to work as hard. Again, only given IV, and the patient's going to require monitoring. Nesretide, side effect primarily is severe hypotension. Okay, now on to organic nitrates or vasodilators. This is nitroglycerin. It's a short-acting nitrate, or isosorbide, which is a long-acting nitrate. Their mechanism of action is very similar. They dilate veins and coronary arteries, and it's that dilation of the coronary arteries that we're interested in. So they're primarily used for angina. They can provide immediate relief of anginal pain, especially nitroglycerin. They can decrease the frequency and severity of anginal attacks, especially isosorbide. And they can increase activity tolerance. Without the symptoms of angina, the patient can be a little bit more active. So nitro, because it's short-acting, is used more for acute attacks of angina. It can be tablets, sublingual. It can be a topical paste. Sublingual tablets are typically used more for acute attacks, and sublingual, make sure the patient dissolves it under their tongue, that they don't swallow it. They can have 1 tablet every 5 minutes for up to 3 times, and they may want to use it prior to activity, just to prevent an angina attack. Topical application of nitro gives longer relief, but doesn't work as quickly, and obviously we know that topical meds don't absorb as quickly, so it's not going to work as well. Isosorbide, because it is longer acting, is used more for prevention. Nitro should be stored in a dark container and replaced every 6 months. It should be kept available at all times. When applying the topical nitro, gloves should be worn, especially if you're not the one using the nitro. If you're the nurse applying it, you don't want to get that on your skin. It's causing vasodilation, and one of the side effects, especially initially for patients, is severe headache. They will develop a tolerance to that. But if you're not using it all the time, you don't want to have to go through the rest of your shift with this severe headache because you got a little nitro on your fingers. Again, topically, sites should be rotated frequently, every application. Preferably an area without a lot of hair so that it gets good skin contact. They may still need PO or sublingual nitro, even if they are using the paste. So again, both of these meds dilate vessels, decrease preload, which decreases cardiac output, which decreases the demand on the heart. They also dilate the coronary arteries, which is going to allow for better blood flow. With nitro, patients tend to develop a tolerance not only to the headache side effect, but also to the therapeutic effect. So they need periodic breaks. If they're using topical, they should take the patch off once a day, and they may need to skip a PO dose. Need to use the smallest dose possible for as long as possible so that we avoid the tolerance to the therapeutic effect. It's going to interact with Smiling Bob's friend, and for those of you who are too young to remember Smiling Bob, he uses one of the Viagra knockoffs. But remember, Viagra, all the Viagra commercials say do not use if you take nitrates for chest pain, because that's how Viagra works, is by causing vasodilation. I believe it may have actually even been initially developed for that intent, only to find that it had other side effects as well. The organic nitrates or vasodilators are best used with beta blockers and calcium channel blockers because it allows for lower blood pressure, better blood pressure control. Diuretics. Now, you might think, well, why are we talking about diuretics? Well, diuretics are buckets for sinking ships. Think about what's going on with heart failure and hypertension. A lot of the problem is related to fluid volume. So we use diuretics to get rid of excess fluid. It's not just because we're trying to get rid of, remove the edema. The edema is caused by the excess fluid. So we need to shift that fluid into the vascular system where it can then go to the kidneys and be excreted. That's going to reduce then the volume in the vascular system and bring the blood pressure down. It helps heart failure. Again, we reduce that volume, then we have less afterload, we have less preload, and the heart can be more efficient. When we're using diuretics, we want to obviously observe for edema. That's going to help us determine its effectiveness. We want to observe lung sounds, weight. If they're on diuretics and they're still gaining weight, then either the diuretic isn't working, or they're not actually taking it, or they're taking in too much sodium, and so we need to monitor those things as well. Patients should be told with diuretics that it's best to be taken in the AM, that they should be weighing themselves, 2 pounds in 2 days of weight gain, or 2 pounds in less than 2 days. They usually need to be talking to somebody about that. Remember that 2 pounds is a liter of fluid, and that can be a significant volume of fluid for someone with heart failure. If they're taking antihypertensives, diuretics are going to increase the effect of those because we're reducing the volume, and so orthostatic hypotension becomes a greater issue. Sulfonamide loop diuretics are probably the most well-known. This is furosemide or Lasix or torsemide. They work by inhibiting sodium and chloride reabsorption in the loop of Henle. You remember that the loop of Henle is part of the renal tubule, and most of the sodium that's going to be reabsorbed is reabsorbed there. And so loop diuretics are the most effective of the diuretics that we typically use for hypertension. One of the advantages of the sulfonamide loop diuretics is that they work well even with poor cardiac output. So even if there's poor perfusion to the kidneys, furosemide is going to work quickly and work fairly well. They do cause potassium loss, and so we want to be aware that not only are we losing sodium, we're losing potassium as well. And so we're going to monitor lab work for sodium and potassium levels and monitor the patient for symptoms of low potassium, which primarily would be our dysrhythmias. So hypokalemia is an important side effect. Orthostatic hypotension, especially if used with other antihypertensives. It can cause hyperglycemia and hyperuricemia, which can lead to gout. If they're allergic to other sulfa drugs, then they may be allergic to Lasix as well. So something to keep in mind. NSAIDs are going to decrease the action of the diuretic because of the action on prostaglandins and decrease perfusion to the kidneys. CNS depressants will cause increase in hypotension. Because of the loss of potassium, DIG toxicity can occur with concurrent use, and oral antidiabetics and insulin, because of the risk of hyperglycemia with Lasix, those dosages may need to be adjusted. Thiazide diuretics typically are going to end in, guess what? Thiazide. So hydrochlorothiazide is probably the most common. Again, they block the reabsorption of sodium in the kidneys. The difference is that they are blocking it from the distal renal tubules. So more sodium is excreted, which is going to in turn excrete more water. They're not as effective as the loop diuretics, but they are still fairly effective. So again, think, how does this reduce blood pressure? We're decreasing volume, and so that in turn is going to decrease preload and afterload, which is going to decrease blood pressure. Again, along with the loss of sodium, we have loss of potassium. That's why it's often taken with a prill, because it balances each other out. Orthostatic hypotension, GI irritation, dehydration, hyperglycemia are side effects. Steroids increase potassium loss. So any of these diuretics that cause potassium loss we would want to watch that. Digoxin and lithium toxicity can occur if used with a thiazide or a loop. Now, while most of your diuretics waste potassium, we do have potassium-sparing diuretics. And spironolactone is probably the most common, but amiloride is also used. They retain potassium in exchange for excreting sodium from the distal tubules. Sometimes we will add spironolactone just for the purpose of retaining the potassium. And again, by using two types of diuretics, we can lower the dose and still get a good therapeutic effect. They should be taken with food. We need to monitor INO with any diuretic use, daily weights with any diuretic use. We do want them to avoid potassium supplements. Consider where potassium is. They may not want to have, especially if they're only using a potassium-sparing diuretic, they might want to avoid foods high in potassium. They certainly want to avoid salt substitutes. Most people don't stop and think that what is being used instead of sodium chloride. Well, in most cases, it's potassium chloride, and this would be a problem for patients using potassium-sparing diuretics. Interactions include lithium. We would see lithium toxicity. ARBs and ACE inhibitors, which cause hyperkalemia already. We're going to see even greater retention of potassium. And NSAIDs, again, decrease the effectiveness of all diuretics. So that's the end of part 2 for Unit 3. And hopefully I can get this out to you. Thanks for listening.